child psychiatrist. I split my time between Stokely Center, so it's a long-term care facility for adults with intellectual disability, and outpatient insurance-based private practice in Lewis. I'm a child psychiatrist, but also with that comes adult boarding. So ID is sort of my special interest within psychiatry. So here we are. My goal is to increase your confidence in treating patients with intellectual disability ID and comorbid mental and behavioral health challenges. So I'm just going to present some strategies for best practice. What am I doing when I'm seeing a patient with ID in my office? How am I modifying my approach? Introduce how common psychiatric disorders might present and some little wrinkles that might be present for patients with ID, and then discuss some treatment approaches for psychiatric illness in patients with ID. And yes, feel free to interrupt me. This is a small group, so anything that comes up, and hopefully we'll have time at the end if there are more specific questions. So the state of ID and mental health. So about 1 to 2% of the population meets criteria for ID. So that's about 7.5 million people in this country. Individuals with ID are more likely than their neurotypical counterparts to have psychiatric. And if we include just behavioral challenges, it's a ton more likely. And their neurotypical peers are already having a lot of mental health challenges. So this is a significant issue. And there's an overall lack of clinical training in treating this patient population. I don't know how many of you guys subscribe to Stat News, but a medical student wrote an article about just how limited this is in this country. In the UK, they require it every year to sort of do some training in seeing patients with ID, but there's really no standardization here. And I think there's a problem of a double stigma. So we have mental health stigma, and then we have stigma of ID. And when we, combine the two, it's a patient population sort of presenting with issues that a lot of people don't want to be treating. And even, within psychiatry, I would say treating patients with ID is probably the thing people are most sort of skirmish about. So there's also the issue of societal changes. So there's been an amazing rapid progress in inclusion for patients with ID. So I do want to acknowledge all the positive forward progress we've made sort of in the second half of the 20th century. But we've also we used to have an asylum model where we housed and clothed and provided basic needs for these individuals. And then now we've sort of inserted them into the community, but maybe not always shored up our community supports at all times for these patients. So they're probably presenting in their primary care clinician offices, but you might not always have the resources to say, okay, here's how we can help you. And schools do fill a huge gap in that. I think schools have probably been a little more proactive in the medical community in saying, okay, we're going to teach people in special education, and this will be a safe home for these individuals. So that's another place where there's been a lot of positive progress. But I think as sort of medical providers, we can continue to learn more and do better. So just some basic definitions when we're talking about intellectual disability. So this means deficits in intellectual functioning that we observe clinically and on a standardized assessment. So this comes up a lot in forensics. So somebody can't just sort of flunk an IQ test and say, yes, I was not competent. I have ID. So you have to observe this clinically, and more importantly, you have to have deficits in your adaptive functioning. So regardless of what we're seeing in testing, it has to show up and impact how you live and whether or not you can completely live independently, and with onset in the developmental periods. This is not a dementing illness. Historically, we only looked at IQ. IQ is very controversial because of some bias in terms of both gender and socioeconomic status. So there's been this shift with adaptive functioning. And then just caveat, just because I do still sometimes see it in notes, mental retardation is not an appropriate term anymore. This sort of, in the 60s, this was going to be the new term, and it's fallen on the euphemistic treadmill, as we say, where it was going to be the more sort of, I guess, kind or friendly term, and now it's been weaponized in society to be an insult. And so now we say intellectual disability as the clinical term. All right. So what am I doing? What am I focusing on in my interviews when I have a patient with ID coming to me with a behavioral health concern? So number one is speaking directly to the patient. So even if the patient doesn't have verbal skills, acknowledge their humanity in the room. You might be getting a lot of the history from the caregiver, but speak to them first. They are number one. Ask about an AAC. If there's another way they're communicating at school, that's something they should be bringing to your office. You're going to get a lot more, from the patient if they're using the way they typically would communicate than not. Utilize the help of the caregiver, right? So speak first to the patient, but it might be that a lot of the history is coming from the caregiver. If there's somebody that is in an institutional setting, absolutely seeking for collateral information from nursing staff or just the people that day-to-day are with this person. So when I'm seeing patients at Stokely, that's always the staff. The staff's with them. They do a really amazing job. They know every little habit of, well, they didn't want their nails done today. So I really think they're, they pick up on things that most people wouldn't. They're really skilled at that. And then be accepting and neutral if things are falling apart. So if the patient is not wanting to communicate with you, if they're limited in their communication, trying not to get frustrated or feel like, I don't know what's going on. If you show that, this sort of clinician related factor, that might influence rapport building. So I always say just going into each interview opportunity, seeing it as an opportunity, wiping the slate clean of whatever's happening and trying to maintain that confident, safe space. And then we always say we want to use open-ended questions when we're communicating with patients. I would say, depending on the level of ID, do use some yes/no questions. So they might not be able to answer more complex questions. It's okay to put some yes/nos in there. However, if you note a pattern, especially in your sort of moderate ID patient where they're using a lot of yeses, you might want to check for understanding. So you might want to say, okay, well, can you explain to me why I'm recommending this medicine if they're able to verbalize and tell you? So yes, no's are okay. Do check for understanding if you're just getting a pattern about one or the other. So with that in mind, just going over what expected communication skills would be depending on the degree of intellectual disability. Most individuals with ID have far better receptive and expressive language skills. So that means that they understand more than they can tell you. So there's probably more under the surface than you're able to get out. Assume that. But if you're not sure, check with the caregivers. Be like, do you think they get it? Or is this right? It's always okay to check in the room. Mild ID, so this is 85% of individuals with ID, so it's IQ 50 to 70. These patients will be verbal. They might be a little bit concrete. They might seem to process a little bit more slowly, but you might not know. A lot of people with mild ID go on to live sort of unassisted lives. They hold jobs, they have relationships. They might be considered normal, but if you then sat them down and made them go back to school again, you'd be like, oh. So there might be some slight concreteness, but you would expect to have a pretty typical conversation, and a conversation that would include, full questions about their symptomatology from a behavioral health perspective. So you might not get really metacognitive on sort of what they're going through, but generally would have great verbal abilities, presuming there's no comorbid autism or something like that. Moderate ID, so this is a smaller portion. This would be about 10% of individuals with ID, IQ 35 to 49. These patients are typically verbal, but may answer questions with a monosyllabic or brief responses. They might give shorter sentences. I like dogs, something like that. So generally their sort of expected age range would be like 6 to 9. So they're speaking with you, they're engaging, but they might not give paragraph-long responses. They might not be as organized or as linear in presenting a history of a depression or something like that. They might just say, I'm sad, if prompted. And then severe or profound ID, severe is about 4% and profound 1% of individuals with ID. And that'd be IQ 20 to 34 for severe, and profound and IQ less than 20. Those with severe ID might have some verbal communication skills in terms of like a word here or there. Those with profound ID almost universally communicate non-verbally. They might recognize a caregiver and give a response when the person comes in the room, but wouldn't be necessarily having a back and forth conversation with you. All right. So when we talk about a psychiatric assessment, what we typically do is we do a biopsychosocial assessment. So we look at biological factors, psychological factors, and then social factors, which might be influencing the patient's presentation. So for patients with ID who are more likely to have comorbid medical illness than your neurotypical child, explore medical causes first, always, if you're having a behavioral change. So especially if it's brand new. So if it's a different flavor of the same, like they've had aggression before and it's happening in a new place or something like that, okay, but they've never been aggressive and all of a sudden are presenting with aggression, really take this seriously in terms of, is there something going on medically? So do a physical exam. Sometimes individuals with ID do not express pain in the same way that you or I might. They might be very stoic about pain. So there might be an injury that we don't know about, that they haven't told you about. Take a medication history, ask about over-the-counter medications that the family might be using. They might think this is no big deal. They might be giving them Benadryl, and then we're having this sort of paradoxical response with activation. And then take a review of systems across. Consider labs. I've had some surprises myself. And then always ask about the dentist and constipation. A lot of dentists don't want to treat individuals with ID. I've had patients come in and new aggression, they're coming to me for the first time and we find a dental abscess. Do ask about this. Same with the constipation. There was sort of a rumor, this is more in the autism community, but autism and ID, there's a lot of overlap, that Miralax caused aggression. And I suspect it probably wasn't. We've done like studies where we're like, does Miralax cause aggression? No, it doesn't seem to cause aggression, but the constipation itself does. Always take a genetic and family history. There's a tendency to say, well, this neurotypical parent with a history of depression, that's not as relevant in the kid with ID who has different genetics. Not really, no. Mental health disorders are heritable. It's still relevant to get this family history. So a risk of depression, that is going to be relevant for the individual with an ID as well, even if it's sort of different than how the family members present. So regardless, if there's a family history of suicide, I'm on higher alert for suicide. And then there are some associations. So if this person does have a genetic anomaly, there are specific syndromes that carry associations with certain mental health conditions. So kids with Fragile X are almost universally hyper. So something to be aware of, something to look out for. There are other things. I'm going to sort of sprinkle in some as we go through. This lecture easily could have been just like a list of different genetic syndromes and sort of the phenotype from a behavioral health perspective, but I'll sort of put them in when it fits the narrative, I'll say. All right, so just to review, I'm just putting this up here as medical conditions that we do associate with aggression. There is a long list. The ones I want to highlight in this population, seizures, constipation, and pain are probably the ones that come up the most for me in med side effects. Some of these are more adult concerns, though, do happen. I've seen delirious patients with ID certainly in the hospital, but med side effects, pain, constipation, and seizures lead to new or unprecedented aggression in my patients almost all the time. So something to always consider when you're having behavioral changes. All right, so moving on to psychological factors to consider. So I always want to know, what is a patient like at baseline and how is this a change? Because sometimes people will come in and they're saying, we're here for this concern. And then I'll ask, what are they like usually? And the family is like, oh, they're always like this. And so it's more of a personality than something we might be modifying through medication, or they're always withdrawn or not interested socially. That's very different than someone who all of a sudden is withdrawing to me in terms of my concerns for a depressive illness. So ask about, is this a deviation from normal? How do they typically handle change? I ask about their routine. So I have a luxury of a little bit of time, but speaking with a caregiver, is there anyone different that's working with them at school? So sometimes I've had patients who their favorite para was moved to a different new student and they started being aggressive towards that new student. And it was a clear adjustment. They didn't want to lose their para. They missed that person and they wanted to get rid of that other student. Have there been changes in the schedule? Are they suddenly on a different sleep schedule? Are they interacting with someone, say the parents are separated and all of a sudden they're spending more time with one parent and then there's an increase in behavior? How do they typically respond to pain? Are they someone who has been stoic? Do we need to be doing more of a workup? And then remember that trauma can have long-lasting effects on coping strategies. So individuals with ID are not immune to having gone through trauma. And sometimes we'll have a trauma reactivation that might be hard to trace. So say someone had an abusive situation at a specific house and you drive near the neighborhood one time. The individual with ID might not say anything in the drive, but later on at school, there's a behavioral disturbance or they're not engaging in work. And I've had that come up a number of times where no one says anything. We don't really know that they were even aware that we drove past the house, but it's there. So just understanding that if the patient has a history of trauma, that can continue to reverberate and have effects for a long time. That can impact how they trust, how they build relationships, and self-soothing in distress as well. And that might persist. And it might not be sort of a classic post-traumatic stress disorder picture where we can say, oh, they have nightmares, there's clear activation or avoidance, or it happened right after the trauma. But just that they have a temperament that's a little bit harder to soothe and a little bit more mistrusting. And then always assess for abuse as a possible contributor to behavioral change. Individuals with ID are vulnerable to abuse and might not have the communication skills or the understanding of, sort of norms or what should be expected, what's appropriate. And then finally, considering the developmental age of the patient. So I have a whole slide on this. So the patient's emotional and behavioral responses should always be evaluated in the context of their developmental level. So a lot of psychiatric diagnoses have this built in terms of qualifiers. So ADHD, if a person has a preschool developmental level, you would expect them to have the attention span of a preschooler. So if they have a teacher who's trying to work with them one-on-one for an hour-long block, we might need to chunk that time. We might need to be breaking it up. It might not be realistic, even with medication, that they'd be, sitting for a whole hour. Same with disruptive mood dysregulation. It is appropriate for preschoolers to have tantrums. Disruptive mood dysregulation disorder says that irritable outbursts have to be inappropriate for developmental age. So just always thinking about where they are developmentally. And then there are some classic early developmental behaviors that often persist in ID. So I get a lot of referrals that are, this patient with ID talks to themselves. They have all this, they sit and they play and these characters talk and it seems like they're talking to people that aren't there. If that patient was 5, we would say that's normal, that's play, that's what kids do. But because they're an older patient, that's sort of red flagged. And again, just considering the developmental age and whether or not it's appropriate. And then finally, just using developmentally appropriate language in your interview. So don't curse, but meet the patient where they are in terms of the complexity of your phrasing and how many questions you ask at once and things like that.
Dr. Leitner, can I ask a question going back, I guess, bordering on both the physical and developmental needs of an individual with ID? I used to work for a Agency for Rare Genetic Disorder, Canadian de Long syndrome, and a lot of times we'd see the aggressive behaviors change around the time of puberty, menstruation, so things beyond, because we used to say, look from the top of their head to the tip of their toes in terms of ruling out physical issues. They can't say I have, a toothache, they're going to lash out or be uncomfortable or withdraw. And oftentimes, we'd see even things developmentally like growing pains, the physical change of their body would be so, even though they had a high tolerance for discomfort, oftentimes, any small catalyst on top of that would really propel them into a real change in behavior. And I know that developmentally not being able to identify the those emotional changes as well, for the young adults who, again, we're going through, and a lot of times precocious puberty was a side effect of that developmental issue. And I just didn't know if you could speak to that around I guess needs of that change.
It's interesting because I feel like it goes two ways. Like some of my patients, depending on their level of hyperactivity, as they sort of reach puberty, sometimes that just energy level calms down and that we see a little bit less impulsivity and some of that sort of just impulse control disorder type behavior decreases. But then others, it seems to almost heighten, like particularly menstrual cycle changes. So I I've had a number of patients who have sort of a PMDD picture, and they seem much more sensitive to hormonal changes. And I don't know that we really fully understand why that is, but I don't know, long-winded way of saying this is a very heterogeneous group. And yes, small changes, medication, hormone, medical, did you poop, did you eat, did you sleep? They seem to be more sensitive to small changes. Yeah.
Thank you.
Okay. So moving on to the social. So things to worry about: financial security. How is this contributing? Think about determining their access to resources. So I think a lot of the time school is providing some of the access to resources, like they might be getting OT at school, but what about home needs for sensory issues? Is there a way we can get more wraparound services? Do you need to make a call to DCPAP and see what other resources are available? Same with psychotherapy. I think sometimes this is particularly overlooked in individuals with ID. There's an assumption that they might not benefit from that. And then sort of vocational or rehabilitation services, looking at how do we prepare this person for an adult life? And then ask about bullying and peer relationships. People with ID are human, they want to connect, but sometimes they're rejected by their peers, and that can be really hurtful. Be proactive, discuss times of transition with patients and their families. So this is sort of the number one thing that leads to adjustment problems in these individuals, is not being prepared for the changes of life. It's a population, like I said, sort of sensitive to transitions anyways, and they have pretty significant shifts depending on their degree of disability and the help they require. And then also remember that relationships are essential. Access to social networks might be variable. So again, they might want friends but not know how to have them, or they might be having a ton of drama with their friends and you just need to ask about it. Same thing with family. You know, they might want independence from their parents but not be able to have it, even more so than a typically developing teenager. And they absolutely do have romantic relationships, and it causes just as much drama as all of us, right? So just remember to ask about this. Don't presume, just because they have an ID label, that these things are not happening. They are essential, and they are, and just remember to ask. Okay, so now I'm going to move through specific conditions, not necessarily diagnoses, because I know I have aggression as non-specific here, just specific conditions and how they might present in individuals with ID and some factors. So starting with aggression, this is most impairing. This is the thing that I think gives families the hardest time, the most fear, keeps kids out of sort of a typical classroom, things like that. It's a non-specific symptom. It's not part of any one diagnosis. So make every attempt to try to identify what's the underlying contributor. So be it a medical cause, or if we're going to attribute it to a psychiatric cause, trying to say, what does this look like? What does this resemble? Are there other associated symptoms, so that we can target the treatment appropriately? So when I have a patient coming in with new aggression or a change in aggression, I'm getting down to the nitty gritty. I want to know, I want to be there. I want like the time-stamped live updates, everything I can find out about it. So what's happening before, what's happening during it? How are we reacting afterwards? What was the timing? Is it a specific time of day? Who's around? Who are we targeting? Is it a caregiver? Is it some new teacher? How intense is it? So I had a recent patient with ID with really limited verbal abilities who had a new para, and the family came to me and they were like, we're so worried they are having worsening aggression at school and they're hitting the para in the face. And we were like, whoa, that seems scary. We were concerned. But the school did a really good job sort of doing a behavioral assessment, seeing what was going on. And it turns out what the patient was really doing is they were tapping the para on their glasses. The para had glasses, and they were sort of pulling on the glasses. And the para, well-trained in positive behavior, had been ignoring it. So they were sort of looking away, doing anything to ignore it. And then the patient was yanking harder. And then finally they were slapping them in the face. And then there was this big response. And what the school tried was, instead of ignoring, the para would say, hey, I see you're tapping on my glasses. Do you need something from me? And then the patient would sort of nod and signal. So it actually seemed like, I always say all behavior has a function. It's just finding out what that is. And when patients can't tell us, it's so frustrating. But the function then was, hey, I don't really know you and I sort of need you and I'm not sure how you want me to ask. And so once I did that, there was no face slapping. It just sort of became a tap to remind him that, hey, I need you right now. Minnie, were you going to say something?
May I ask, I was going to ask one more question in regard to behavior as a form of communication. And, you know, they say like if a tree falls in the woods and nobody's there to hear it, does it still make a noise? So looking at the behaviors that would occur, whether someone is observing them or participating with them or not, things like self-stimulating or, you know, self-abuse, you know, those things would still also be counted as communication, you know, that the person is trying to make an adjustment or a self-soothing or self-stimulating.
Interesting. So it sort of depends. Sometimes I think stimming it's communicating something about the mental status of the patient, right? But not all, there's an element of it that's almost like not volitional, like it's not even voluntary. They don't even realize they're doing it. And it's up to us to point out, hey, you're doing this. Can we redirect to something else? So that I feel like the intentionality is a little bit more muddied because sometimes it's so stereotyped as to be almost compulsive, if that makes sense. So sort of like a tick, where you're not completely thinking through an intention behind it. Whereas like a more complex behavior, like going up and grabbing someone in the face like that, okay, you need something. But like a self-stim, like a mouth thing, right, where you do the self-biting, self-stimming, that might be just more, I have a feeling and I need to do something about it. So it has a function. Is there an intention in doing it to signal to others? Maybe not. Does that make sense?
It does. Thank you so much.
Yeah, no problem. So yeah, is there a function of this behavior? I suspect there is, but we might not know it. And then is there an association with aggression and regression in function? This makes me worried about medical cause or even something more insidious, like is this a catatonic process? Individuals with IT and individuals with autism are more prone to catatonia from a psychiatric perspective. And then is there an association with any sort of neurovegetative signs? Have they changed their sleeping habits, appetite, energy? Are they withdrawing from their usual activities? This would make me worried about a depressive illness. So psychiatric illnesses that are on my differential, if we've ruled out medical causes, somebody with ID is having aggression, I worry about impulse control disorders. So is this a person that's always been oppositional and they're sort of wielding aggression a little bit indiscriminately? Is this a person who's just explosive? We often use unspecified impulse control disorder in ID. It's sort of hard to meet criteria for intermittent explosive disorder depending on your communication abilities, because intermittent explosive disorder requires that it's sort of either unprovoked or sort of like doesn't fit the scenario, and I don't always know what the cause is. So sometimes I'm saying it's an unspecified impulse control disorder because I'm really not sure. Maybe to them this was a big deal and they just weren't able to tell me what the issue was. And not being able to communicate is in fact quite frustrating and might lead someone to, you know, do pretty grave things to try to get somebody's attention. ADHD obviously can come with aggression. Anxiety, often there's sort of, instead of internalizing anxiety, we have a lashing out or an externalizing. Psychotic disorders can lead to aggression. Antisocial behavior, and by that I mean more, I'm going to hurt you to get what I want, and I don't care about the consequences. Mood disorders can lead to aggression, similar to anxiety. I think we think of this as turning in, but often it's turned outwards, particularly in adolescence, across the board, in typically developing youth and not. Adjustment disorders, think about this around times of transition. Are we frustrated with somebody because things are changing? So sometimes we'll see kids at the end of the year, suddenly they're aggressing towards teachers. And then substance use. Individuals with ID are less likely than peers to use substances, but never assume, right? And then I have had some really unfortunate situations where parents have a belief about a substance and they think that their child might calm down if the child receives that substance as well, particularly with cannabis. So I've had a few young kids with ID whose parents have given them cannabis, and we drug test everyone that gets admitted to psych units. So yeah. Okay. Aggression in individuals with ID ongoing. So the risk of aggression, just some specific features within the ID population, risk of aggression increases the more severe the ID. And then other conditions that increase risk of aggression, almost these are all pretty much associated with more severe ID: sleep problems, polypharmacy, having seizures, and having CP. I would work, like I said, to identify the underlying cause rather than just sort of indiscriminately targeting with pharmacotherapy. So before you throw on an atypical antipsychotic in this patient, try to target, is this depression and we're going to do therapy and then maybe an SSRI? Or has there been a big change and we need to reassure them that the pair is coming back? Things like that. For individuals with mild ID in a forensic setting, CBT was helpful in reducing aggression. So therapy, consider it. All right, so moving on to self-injurious behavior, SIB. This is poorly understood sort of across the board. So we see SIB across cultures. It's been observed for hundreds of years, most common in adolescence. The classic great sort of neurotypical adolescent SIB would be cutting in the setting of emotional distress. It's poorly understood in ID. It seems more common than in our typically developing youth. I mean, typically developing youth is like 10%. So it's even more common in ID. Behaviors are more stereotyped. So that would include head banging, hitting oneself, and the hand biting. Sensory impairment and difficulty with self-expression are often present, associated with more severe ID, poor communication skills, and comorbid autism. I always consider referring to OT to help with sensory needs first. So especially if a patient's like head banging, they're running into the walls, things like that, they might benefit from a crash pad. And sometimes what will happen is at school, they have these great sensory rooms they can go into, and, you know, they've got a wiggle chair and these fidgets, and, you know, they're crashing into stuff at school, and then they come home and they're like destroying the house and families don't know what to do. So this is sometimes when I'm thinking about, can they get outside OT to help? And then the other thing is they have these like oral fidgets that I've had for some of my patients that bite their hands. So they look like shark teeth. You can get them on Amazon. And so my patients will like have these shark tooth necklaces. And so they'll bite those with some redirection and prompting instead of like biting their hands, where sometimes those will get infected. And I guess it's sort of one of those things that, like, if they do it and it's sort of a mild callus and it's not that problematic, it's something I'm willing to just sort of monitor. But if it's causing sores, if there's a hygiene issue, anything like that, then I'm more likely to try to address it either behaviorally or then eventually with pharmacotherapy. Some specific syndromes to worry about. So if a patient has not had genetic testing and these things are coming up, or if they have the specific syndrome, be watching out for these things. Lesch-Nyhan and self-biting, which can be quite destructive. And then Smith-Magenis and fingernail pulling. All right. So moving on to autism and ID, this slide probably doesn't do the, interrelationship between autism and ID justice. I mean, autism and comorbid psychiatric illness is its own lecture. I'm giving ID its moment to shine today, but I think certainly, there's plenty to talk about with autism alone. So I'm just going to give a nod to this, but knowing that it's just not ample time to talk about all of it. But we know autism is characterized by deficits in social communication, repetitive patterns of behavior. About 10% of people with ID meet criteria for autism. The flip is greater. So 40% of individuals with autism meet criteria for ID. There's clearly some sort of genetic link given the number of syndromes that are associated with both, though we really don't understand sort of what that link is. They're, across chromosomes, different, very different causes. Co-occurring psychiatric disorders are common in ASD, including social anxiety, ADHD, and ODD. We see self-injurious behavior in up to 50% of individuals with autism. So it's really quite common. For those with autism and ID, this is probably the most important part of this slide. What families say is most distressing is SIB and aggression, which makes sense, right? Nobody likes violence. So those are things families are probably going to be coming to you and saying, what do I do about this? This is so distressing. All right, moving on to ADHD. So ADHD rates are probably pretty similar to the general population in ID, maybe slightly higher. I think at some point this was probably overdiagnosed, especially when we consider stimulant responses. So if you're considering developmental age, I wouldn't necessarily say there's a huge increased risk of ADHD and ID, depending on what the cause is. I think fetal alcohol syndrome would be a big exception, and autism as well. So if either of those are present, I'm more concerned for ADHD, but, and then Fragile X would be the other. So also include an impulse control disorder on your differential. So a lot of times I'll see patients who have an ADHD diagnosis with ID, and they're doing sort of these impulsive behaviors. They've struck up here. We didn't know if there was anything going on, but then they're not really that inattentive or hyperactive relative to their developmental level. They've had multiple stimulant trials. The stimulants don't seem to be working. So they're coming to me for ADHD med management. And I don't really think that's sort of like an appropriate diagnosis. So just consider that it might be more impulse control problems instead of ADHD in patients like that. All right, moving on to anxiety. Individuals with ID are likely underdiagnosed with anxiety disorders. They may not be able to identify anxiety as a cause of distress, and we might mistake sort of upregulation and activation that goes along with anxiety as like agitation, instead of understanding that there could be some sort of internalizing symptoms. So things you might see if a patient is anxious, some avoidance. So if there's something they don't want to do and they're avoiding it, don't presume it's oppositional. It might be they're anxious about it. Autonomic arousal, if you see them, they're sort of like keyed up, breathing hard, blood pressure's up, things like that. Think maybe they're anxious. Aggression, agitation, compulsive and repetitive behavior. So Mindy alluded to this, like if they're doing more self-stimming, if they're doing more SIBs around a certain situation, it might be that situation's making them anxious. Self-injury, I just said that. And then insomnia. Panic is very interesting. If you think about a typically developing adult who gets a panic attack and freaks out and calls 911 because they think they're dying, and this is a person who might have education on what panic looks like or the connection between the mind and the body. And someone with ID, if all of a sudden you get this surge of feeling like you're about to die, you can't breathe, what is going on? I've had patients come to me for consults for they saw a ghost in the room and I don't know what was happening. They might fully look delusional or paranoid. They're screaming, they're crying, they're falling on the floor, but it might be panic. So consider that if sort of patients are having these like paroxysmal episodes where there's this huge rush of emotions. It doesn't last very long. They seem to be calmed, and then try to figure out a pattern. Is this sort of something provoked? Is there an anxiety that's reproducible, or are they just anxious all the time and panic is breaking through? All right. So prevalent rates of depression, moving on to depression, have varied a lot between studies. Some have reported lower than expected rates compared to the general population. I don't know if I buy this. I think this might be similar to anxiety, where we might not be very good at screening, just given the stress and the stigma and everything that people with ID face. It would surprise me if they were less likely to be depressed than their typically developing peers. So things to look for: irritability, sadness, crying for no reason in those that aren't verbal, sleep and appetite changes, not just low mood, but also mood lability. So when their mood seems to shift very quickly, or they're very sort of seem more sensitive, social withdrawal and isolation. So it's stoically, almost all the patients that I see are, they don't have any verbal abilities. And so what we look for is, do they brighten when their preferred caregiver comes in the room? Or if given an opportunity to do some sort of outreach activity, do they want to do it? Are they interested? Are they spending more time in their room? Are they interacting with their roommate? Things like that. And then even though, like I said, depression we think of as turning inward, sometimes it turns outward in individuals with ID. So you might have more aggression and self-injury, particularly the more severe the ID. All right, so there is an increased risk of psychosis, either schizophrenia or mania with psychosis in individuals with ID. But beware of overdiagnosis. I know I've brought this up a few times. I've had anxiety misdiagnosed. I've had sort of imaginative play misdiagnosed. So self-talk is really quite common. Down syndrome, more than anything, there is an association with self-talk, sort of throughout the lifespan. So that's just something to be aware of, that self-talk is not necessarily psychosis. And then one syndrome to bring up, the 22q deletion, is associated with both psychosis and ID. So if someone has that and there's something sort of psychotic, like, I do take it more seriously. Not that I wouldn't take psychosis seriously regardless, but I am searching for it if they have a 22q deletion. All right. So what do? We have all these things. What are our treatment options? So 99.9% of the time, I'm recommending therapy regardless of the behavioral health issue in an individual with ID. So individual psychotherapy can help improve quality of life and reduce psychiatric symptoms. So don't overlook it. I think sometimes it is. So evidence supports cognitive behavioral therapy. And when we talk about cognitive behavioral therapy, I always think about CBT as your side view mirror. So it says objects in mirror are closer than they appear. So we want to correct distorted thinking. So somebody has a thought, it's an anxious thought, say they're studying for a test. And their thought is, I'm definitely going to fail the test. And so they feel nervous and like they stink. And then their action is that they don't study and then they do poorly on the test. This confirms their automatic thought that they are dumb, and then lather, rinse, repeat. So that goes through sort of the thoughts, feelings, and actions part. In someone with a sort of like less complexity for abstraction, I might be focusing less on that automatic thought or what their core beliefs about themselves are that are leading to these automatic thoughts, and focus more on the behavioral aspect. So in an individual with ID, it might be, hey, you get this feeling. It feels funny in your belly, like there are butterflies. What do you do when this feeling comes up? And focusing more on how do we replace this feeling with a new action of deep breathing. So again, it's sort of like little c more b. So more behavioral therapy. Social skills training also has evidence for individuals with ID. So these are focusing and learning social skills. So shaking people's hands, looking them in the eyes, what to do in conversation. Applied behavioral analysis is used. This is probably the most common modality used in the schools with great success. And then family therapy as well. Lots of times it's hard for families. No kid comes with a primer, but a lot of kids with ID have sort of special needs in parenting, and helping families navigate and feel competent can really improve those dynamics in the home. So some other examples of non-cognitive strategies, I talked a little bit about sort of focusing on the behavioral, just basic relaxation techniques. So engaging somebody in yoga, in breathing, in self-monitoring. So that would be journaling. So little small reflections might be appropriate. So sort of like star charts could be a form of self-monitoring. And then skills training, just like I talked about, that can be parent skills or social skills, most commonly used. All right, so some topics to explore. You're thinking, what would I be referring a patient with ID to therapy to talk about? Have I mentioned life transitions? So this is number one. So transitioning from one educational program to another. So even going elementary to middle school could be a huge transition that might cause a lot of distress. Transitioning from school to occupational setting is significant. Moving from family into a supported residential environment. Aging of caregivers. What's going to happen to me? Is my sibling going to take me in? Where will I be? And then this is particularly common in those with mild ID, a mismatch between the desired level of independence and the practicality of what they're able to do. Some internalized stigma regarding having an ID diagnosis, or what does it mean that I have an IEP, or why do I have to go to this class, this resource class? I don't want to participate in it anymore. I don't want to be different. Again, particularly in those with mild ID who are going to be more aware of those small differences and will often blend with their peers. Relationships. Relationships are important. Relationships are, for all of us, this is the content of love songs for a reason, right? Plenty to talk about in terms of relationship, be it friends, parents, peers. And then finally, parent skills training groups. So if the parents are feeling overwhelmed, sometimes being in a group with other parents and arming them with skills, but also having that sort of peer support, it can be really isolating when, you know, all your friends or neighbors are raising sort of a typically developing child, and you have this child with ID to feel like we are just not on the same page. We're not doing the same activities. We're not able to do the same things. We're not getting the same positive feedback from society. So having other parents that are the same boat can be great. If you can't find a parent skills training group, sometimes, especially if the patient has a specific genetic or rare disease diagnosis, support groups, even online, can be really life-saving for parents. Just knowing, like, what do I need? What should I expect? Like the puberty thing you were talking about, like, they're going through puberty. How did you guys get through this? What are some strategies? And someone just validating that experience so they don't feel alone and sharing tips. All right. So moving on to psychotropic medications. So I say this with a caveat. Psychotropics have historically been used in the ID population for their tranquilizing effects alone. Self-reported side effects could be compromised by limited communication abilities. So up to 85% of the individuals with ID taking psychotropics have some sort of side effect. So it's the rule, not the exception. We really don't know why. Hypotheses have included metabolic, pharmacodynamic, and kinetic differences, or maybe there's CNS differences in some of these patients leading to drug reactions. We're really not sure, but I sort of presume, and when I'm weighing the pros and cons, that my patient will have some sort of side effect. It's just whether or not the risk-benefit calculus works out. So general advice, treat as specifically as you can. So know what you're treating so you have a better evidence basis to support this in general. So if you're treating depression, go with the general evidence basis for depression. So you would start with therapy and an SSRI, anxiety, the same. Start low and go slowly. So wait to see if there's a treatment response before you move on or add something else. And then try to minimize polypharmacy. So say you start Prozac and the patient is a little activated and suddenly they're not sleeping, don't then add something else for sleep at night, things like that, because then there can just be sort of a cascade of more medications. All right, so now I'm just going to go through different medication classes and the specific evidence basis in ID. Anticonvulsants are among the most commonly utilized medicines for mood and aggression in these patients. So 20% of patients with ID have epilepsy. So a lot of patients are already taking these meds. Valproate is probably gold standard if you're going to be in this class. It's the most studied, and it has decent support for use for both mood, low mood depression, and aggression. Obviously, it comes with some negatives. You have to check levels. You want to be within a therapeutic window. And then you have to check labs in terms of other possible side effects. So you have to have a patient that's able to take it consistently and able to sit for labs, which at times for me is limiting. Carbamazepine and oxcarb are also utilized. I will say the data is less convincing. If a patient has epilepsy and they're already on one of these medicines, it's not one that I'm like, oh, you should get off of it. But I'm also pretty much never starting these, if that makes sense. And that goes for pretty much any psychiatric disorder. I think there was a time they were a little bit more in vogue, but I'm almost never starting them. I will say never starting them. I'm almost exclusively taking people off of them, or if it's for epilepsy, then I'm sort of leaving it. The ones that I am encouraging and working with the neurologist and saying, I don't know if this is the best one, would be levetiracetam. So we do have a pretty clear record of aggression, irritability, and low mood associated with levetiracetam. Brevitiracetam seems to be maybe lower risk, but I've still had bad experiences with that one as well. So I know there's a lot of ease in terms of use from a neurologist perspective, but if a patient is put on that and then suddenly they're having worsening irritability or aggression, consider whether or not it's the antiepileptic. And then just to round out the antiepileptics, topiramate was studied in Prader-Willi for appetite suppression, and there was this sort of side benefit that it helps skin picking in those patients. So consider that. Because topiramate's a little bit more benign than some of the other antiepileptics, and the skin picking can be pretty debilitating. All right, moving on to lithium. So there is some anti-aggressive benefit in limited studies of patients with ID on lithium. There's a number of concerns with lithium. It sort of has effects. There's significant endocrine effects, renal effects, and it's neurotoxic, frankly. So there's this cognitive dulling and apathy that occurs in patients on lithium that would be a really unwanted side effect in a patient with ID. So it's really rare that we're going there. So I would worry about that. If you have a patient who has ID and somebody's putting them on lithium, it would give me pause for sure. Naltrexone, an opioid antagonist, there is some pretty good data for reduction of SIB, especially if it's the stereotypic type. So it's not as good for cutting. I've seen some sort of like extrapolation used for cutting even in neurotypical kids. Doesn't seem to work that well for that, but the more stereotyped sort of stimming type SIB, there's some okay data for naltrexone, and it's a pretty benign medication. In younger, smaller children, we start at 0.5 milligrams per kilogram. It's generally well tolerated. So if the SIB is sort of meeting the threshold of needing a medication and they don't have like the comorbid depression or anxiety that I'd be thinking about an SSRI, I do think about naltrexone. Or if they're already on that and they're still having the SIB, decide it. All right, moving on to antipsychotics. So these are probably, I don't know, the most overutilized medication in this patient population. So up to 50% of institutionalized patients with ID are prescribed antipsychotics. These obviously come with a ton of side effects. Patients with ID have a greater risk of developing tardive dyskinesia. There are a lot of older patients with ID out there in institutions who are on old school antipsychotics. Tardive is really hard to diagnose, especially in a patient population with more severe ID who might already have unusual and repetitive motor movements. And so I think a lot of times this gets missed. So atypicals, obviously, there's a lower risk of tardive, though not no risk. So I think we don't see it as much in some of the patients that were sort of brought in more recent years. But the atypicals still come with their own risks in terms of metabolic syndrome. And I think this is probably the medication class that is most used as a convenience for caregivers instead of treating an actual medical cost. That being said, aggression sometimes needs to be managed pharmacologically, and Risperdal has pretty good evidence to support its use. So if you're going to go there, Risperdal is probably the one with the most evidence. Aripiprazole has evidence as well, with the caveat that the studies were supported by the manufacturer. I generally, if I'm going to go there, I'll start with aripiprazole and then go to risperidone, mostly because of a slightly more benign side effect profile with aripiprazole, though we sort of couch it as weight neutral, and anecdotally, I've had patients gain like 40 pounds. So watch for metabolic syndrome regardless. Clozapine, olanzapine, and quetiapine have also been trialed in small studies for a range of disruptive behavior in ID with positive results. So these are good alternatives if for whatever reason your patients don't do well on aripiprazole or risperidone, with the exception of clozapine, which requires weekly blood monitoring and has a whole host of side effects. That's sort of a last resort for somebody in an institution for me, but you could consider olanzapine or quetiapine, particularly if you have a patient who you're not as worried about weight gain and they don't sleep. So aripiprazole and risperidone are not that sedating, but olanzapine and quetiapine can be quite sedating. So if I have a patient who's skinny and they don't sleep, I might use those as an alternative if they have significant aggression. They're also a little bit better mood stabilizers than risperidone. So if I'm concerned for some sort of bipolar illness underlying, I might go that route as well. All right, psychostimulants. So stimulant responses are supported by evidence, but watch out for higher than expected rates of emotional lability and tics in the ID population. Again, I think part of sort of psychostimulant response rates being a little bit low, it might be overdiagnosis of ID in this patient population, or sorry, overdiagnosis of ADHD in the ID patient population. All right, moving on to SSRIs. Like I said, these are a mainstay if I'm concerned for any sort of mood or anxiety disorder, or even an impulse control disorder that's not responding to therapy. I will go with an SSRI. Yeah, I usually try to go this route before I'm getting to atypicals. Be aware, though, there is a greater than average risk of activation and increased energy in the ID population. For that reason, I'm rarely using fluoxetine or Prozac. That's the most activating of the SSRIs. Sertraline is a little more calming, gentle, though beware of GI side effects, though most of these patients are constipated and it gives you diarrhea. So sometimes I'm using that to my advantage as well. There is also some data to support use for SIB. So if there's somebody with SIB, they're anxious, I'm usually going to an SSRI. The only one side effect that's a little, like I said, these patients are sort of prone to side effects in places you would not expect them. We think of SSRIs as very benign. I have had a couple patients now get hyponatremia, patients with ID get hyponatremia on very low doses of SSRIs. So something to be aware, if a patient is having, a little bit of anxiety, you started an SSRI and all of a sudden they're having like huge behavioral or mental status changes, do consider that. Moving on to the tricyclics, I don't use these. They come with an increased risk for anticholinergic side effects, which sort of has undesirable cognitive effects for this patient population. And then so many of these patients have comorbid medical problems. So I worry about decreasing the seizure threshold and the cardiotoxic effects. So think about this if you're using these for sleep or enuresis or something like that, that you might have some confusion or cognitive dulling if you are using these medications. And then finally, benzodiazepines. These are meds that I really try to avoid in the ID patient population. People with ID are at an increased risk of confusion, delirium, and paradoxical excitement with benzos. So sometimes I'll have patients or families that are like, we just need to go on a trip. Like, can we just have something that they'll like sleep on the plane or the train? And I will have them try hydroxyzine at home before I will go to a benzo, mostly because I did have one patient in residency who I gave like 0.5 of lorazepam and said, okay, try it at home. And they were like running naked through the street. So they were just like completely paradoxically excited and disinhibited. And so I'm just really, really cautious there. Yeah. All right. And then this is where I sort of get a little personal and share. So middle picture is me with my sister and my brother. So my brother Carter has Fragile X syndrome. He has moderate intellectual disability. He was diagnosed when he was 18 months. He had global developmental delay. This was the 90s, so we had just sort of figured out the Fragile X gene, but I have a maternal cousin who was older and had had a host of issues as a young child, and he had been diagnosed. So as soon as my brother was delayed, he got tested. He had a lot of issues as a young kid. He was really hyperactive. He was like always running everywhere, had a lot of self-stimming, a lot of sort of impulsivity and difficulty with emotional self-regulation. So it was hard to take him places. He was really difficult to toilet train. Like even he was like 12, 13, and still sometimes like when he had to go, he would like drop trowel and pee on a tree if we were somewhere. So it just, it was just a lot of support was required, I'll say. So my mom stayed home with him. He had special education support, had really great OTs and teachers, and a great pediatrician who was pretty proactive in working with my parents on getting him services and thinking about what next steps would be. And yeah, he was one actually, Minnie, it's sort of funny that you asked that he hit adolescence and he really chilled out. So the sort of hyperactivity reduced, like when he was 7, we went to Disney World as a family, and his OT from school gave him this like weighted vest. So because he does this jump thing, that's one of his stims, is he just like repetitively jumps so that he wouldn't like, enter space as we were on Space Mountain is sort of how we put it. And it was a tough, like he eloped, like we had to call the Disney police. I mean, it was like touch and go there. But now, I mean, he's in his 30s now. He's a pretty calm, laid back, easygoing guy. He goes to an adults with disabilities day program near my parents' house. where it's sort of like a school, it's through a mega church that sort of funds a school-based program almost, so that he has like a classroom, they do like a Christmas play, and they make sandwiches for the homeless, and they do outings at the mall, and they get a lot of enrichment. And that's partially subsidized by his SSI. And yeah, he plays tennis. We took him to Europe. He likes tubing. He holds my children. That's him and my baby. And the bottom corner is him and my husband, who have a lovely friendship. My parents, he still lives with my parents. Ultimately, he's gonna live with my husband and me. So we're in a fortunate situation that we can do that. We can continue to support him. But yeah, I present him just as sort of ground, like, this is my why. This is why I became a child psychiatrist. So I went to med school. And yeah, this is why I'm sort of hopeful for, you know, so many of my patients, that like, he has a wonderful full life. He is loved and has friends. He's, you know, he's always like wants to have his friends over. And yeah, he's really benefited from his community supports. And so it is all good. All right. So some take home points. Patients with ID have significant behavioral health needs. Take a thorough history, including collateral and a physical exam head to toe. Talk directly to the patient, acknowledge their humanity. They probably understand more than they can tell you. Therapy can be helpful. Please refer to therapy. And then go low and slow with psychotropics. Wait for therapeutic effect.